We utilize a standard level of pressure support based on the size of the endotracheal tube. And the kind of idea behind this is that this added support is overcoming the resistance of the breathing tube. However, I'll give you this caveat. There are lots of studies that support the idea that actually pressure support is over-supporting the patient, and that you don't actually need the pressure support in order to overcome the resistance of the tube.
Hi, everyone, and welcome to the PedsCrit Podcast. My name is Zach Hodges. I'm a current pediatric ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin. I'm a critical care fellow at Children's National in Washington, D.C.
Alice, will you remind our listeners what we do here at the PedsCrit Podcast?
Absolutely. PedsCrit is a collaborative educational PICU podcast. We work with pediatric critical care educators around the world to create high-yield blog and podcast episodes on core PICU topics. They taught us how to intubate, and now they are teaching us how to extubate. Zach, who are we talking with today?
So today we're excited to have Dr. Alyssa Stoner and Dr. Gina Patel back with us on the show. Dr. Stoner is an assistant professor of pediatrics at the University of Missouri-Kansas City School of Medicine and a practicing pediatric intensivist at Children's Mercy Kansas City.
Yes, and Dr. Gina Patel is a third-year critical care fellow at Children's Mercy in Kansas City. Next year, she'll be doing formal cardiology training at Nemours Children's Hospital in Delaware, and we look forward to working with her in a CICU near us soon.
Fantastic. This is part 2 of our series on extubation readiness. Let's get right to the content. Okay, shall we move on to upper airway?
Yeah, so the next kind of step, so you go down from your head, you get into your neck. So this is going to be your kind of oropharynx and upper airway. And so thinking about what things are going to impact your ability to get extubated or stay extubated. So one of the things that I really harp on with our fellows is making sure you know their previous airway history. So was this patient a difficult intubation on their first intubation or the intubation that got them into the unit? Is their endotracheal tube the correct size? So oftentimes or many times we'll get kiddos who are intubated like at a referring facility, and all they had was a 5-0 cuffed endotracheal tube, and the child maybe needed a 4-0. So thinking about those things, were there multiple attempts for the intubation that could then lead to airway edema? And sometimes when you have a kid coming from a referring facility, you don't really get their intubation records, and you may not know the details, so you really have to rely on kind of that verbal report of like, oh, they said they attempted 5 times during the airway attempt, and so you just kind of have to take it for what it is. When the kiddo is intubated by somebody within our facility, you can go back into their medical record, look at their previous anesthesia note or look at the ED note and have a good understanding of what their intubation attempt was like, because that will really affect what their airway is currently, particularly if it is relatively close to when they got intubated. So for example, like if the kiddo has only been intubated for the 24 to 48 hours because of seizures and they got intubated in the ED, that's going to provide you with good information, right? If it was like 2 weeks ago, maybe it's less important. And then thinking about a leak. And so I think we can talk a lot about like, does a leak really predict extubation readiness? And this is kind of one of the points that I like to make with the residents and the fellows. So we always ask our respiratory therapists to check for a leak. And so this is where I kind of ask and pause and say, well, what does that mean to check for a leak? So Gina, do you want to talk a little bit about what that means?
Yeah, you can take a flow inflating bag and you attach it to the end of the ET tube and you apply a PIP of about 20 to 25 and you auscultate or you listen for a leak around the ET tube. So there should be just an extra whoosh, sorry for a lack of better terminology for that, of air. And so you see how much pressure you need to generate that. So sometimes RTs will start with maybe even a lower pressure around 15 and then work that up if they don't hear a leak and then go up to a PIP of 20 or a PIP of 25 and PIP of 30. And so what I generally ask is, do we have a cuff leak? If it's a yes, then I ask at what pressure, at what was the lowest pressure we were able to generate a leak. And so with that, I can have an idea of, do I need to give this patient steroids, or can I anticipate this patient to have upper airway obstruction and stridor post-extubation? And so I can be prepared for that.
So Gina, if you were told you didn't have a leak on a patient, what would you do?
So generally I would deflate the cuff and see, even with the cuff deflated, do we have a leak available? I mean, it depends on what my timeline is for extubating the patient. So if I'm going to extubate the patient in the next 24 hours, can I reevaluate for a cuff leak within the next 6 to 12 hours? And if there still isn't a cuff leak present, then can I give a dose of steroids? So I tend to lean towards giving a dose of steroids if I don't have a cuff leak, as long as there's no contraindications for the patient receiving any steroids. Generally, there aren't, but you want to make sure you can give an airway dose of Decadron, about 0.6 mg per kilogram, and see if that will allow some swelling to go down, and that will generate a cuff leak.
What happens if you gave your steroids and you get ready to extubate and you still don't have a leak? Are you going to extubate?
Well, it depends on the situation. So it depends on what the airway looked like. Once again, it's sometimes difficult when the patient comes from an outside facility. But if I kind of have a general sense of how many attempts needed to be made to intubate the patient, if the patient has any external deformities, all the assessments that we make when we typically intubate a patient, you can still make those assessments even with the breathing tube already in to anticipate what kind of airway the patient may have. And so generally, I still lean towards extubating the patient even if they don't have a cuff leak, but it also depends on, do I need to deem if the patient is going to be a critical airway or not? And if I feel like they're going to be a difficult airway, then I may wait and give additional doses of Decadron, or I may ring my anesthesia or ENT colleagues to help me out and maybe doing an extubation or a more controlled setting in the OR.
Great. That's a perfect answer. So I would 100% agree. And the reason why I bring this up is because we know that not having a leak does not predict your ability to be successfully extubated. And so that's part of why I have this discussion is, we go ahead and we give the steroids and we do these things. And there's some data that really does support giving steroids, but a lot of it is pretty variable. And of course, we don't have like our nice randomized control trials in pediatrics to look at utilizing steroids for a leak versus not a leak. But there is some support. So Alice provided an article that actually looks at RSV bronchiolitic patients where the use of steroids really was helpful in preventing stridor in the setting of getting extubated. And so I think there is enough support to say that it could be helpful and it's not harmful. And so if we want to provide the patient to be the most successful as possible, it's certainly worth giving the steroids, but also being mindful that you may not get a leak. So it is okay to try extubating. And I've been surprised. I've had a couple of kids where I'm like, oh, certainly this kid's going to have a ton of edema. They're going to have stridor. Like, I'm going to have my racemic epi and be ready. And then you pull the tube and they're like, I'm totally cool. Totally fine. And so they surprise you. Go ahead, Alice.
Oh, no. Yeah, I was going to say, do you have a lack of leak because of inappropriately sized tube, because of traumatic airway edema, because of like airway anatomy, or because of airway edema from maybe fluid overload overall? Like the patient in our vignette, she required dialysis, she had pulmonary edema. Do we need to dry her out a little bit more? And maybe that instead of steroids.
Yeah, exactly. So there's definitely multiple combinations that could contribute to not having a leak. And I think when we're thinking about the patient as a whole, it's helpful to remember the underlying pathophysiology. So exactly like you said, do we need to do maybe a dose of steroids and some Lasix to kind of optimize things appropriately depending on where we're at?
So my understanding, when next time I see this patient, we're getting ready to extubate and we don't have a leak, don't let that be an absolute contraindication, but maybe just use that as an opportunity to consider their patient's risk of post-extubation stridor. Like, do they have a history of airway surgery? Were there multiple intubation attempts? Is there something about this patient that would set them up to be higher risk for having upper airway obstruction after that tube comes out?
Exactly. So if I'm worried that they are going to have upper airway obstruction, I will ask the RT to bring racemic epi into the room. I think I just have anxiety when it comes to these patients when you extubate them. Oh, yeah. So my biggest kind of pet peeve is like you're standing in the room, the kid is retracting, they have like audible stridor, and they're like, oh yeah, let me go get the racemic epi. Oh, can I get an order for that? Because I can't override it. And you're like, So I oftentimes will just be like, will you guys just appease me and please go grab the racemic epi and have it at bedside so that way if we need to give it, we can give it. I don't always give the racemic epi if the child is having work of breathing and stridor. That's kind of my indication to give the racemic epi. And if I give the racemic epi, then I typically will schedule 3 more doses of dexamethasone kind of at that 0.5 milligrams per kilo and give them just 24 hours total of steroids, but then not anymore.
Sure. So maybe dose those steroids every 6 hours or so till you get 24 hours in total.
Yep.
Okay.
Exactly. And then the last piece that I think about is really about can the patient manage their secretions? And so this becomes more of an issue for patients who have experienced a new traumatic injury or for kids who have chronic posterior pharyngeal tone issues. So these are the kids that are on Robenal or glycopyrrolate at baseline. And so trying to understand how many secretions do they have and where are they coming from, right? So oftentimes we'll get from the bedside nurse oh my gosh, they have copious secretions. And you're like, oh my gosh, why are their lungs still sick? And then you further inquire and they're like, oh yeah, the secretions actually are just coming out of their mouth, and so these are the kids who have lots of salivation and really need help controlling those secretions. And so I always ask, where are the secretions coming from? Are they coming out of the mouth or are they coming out of the breathing tube or both? And so getting a good sense of, are they able to manage their secretions coming out of the breathing tube? So do they have a good strong cough where they would be able, if the breathing tube comes out, they can cough them up and get rid of them themselves. If they don't have a good strong cough and they have copious secretions coming out of their breathing tube, that might be a time in which I would pause and kind of reconsider and say, okay, is there something else that we need to do to kind of optimize their therapy? Do they have an underlying tracheitis that we're not treating effectively? Do they have something else that's contributing to these secretions? Sometimes there's kids who just make a lot of secretions because they have plastic in their airway. And so you just need to be cognizant of that too and kind of try to figure that out. And you just have to do that on a case-by-case basis. In a child who I'm very worried about their posterior pharyngeal tone and their level of oral secretions, one of the strategies that I have utilized is before extubating, I give them a dose of glycopyrrolate with the idea that their secretions will be all kind of cleared up and that won't be a confounding issue right in the peri-extubation phase. Now, they may not need ongoing glycopyrrolate, but just kind of surrounding that time of extubation.
Oh, yeah. And those hypotonic kids, I can picture exactly who you're talking about. And I feel like those are the ones where you suction as much as you can, you pull the tube, and occasionally they'll end up on BiPAP and make everybody really nervous. Can you picture that?
Yeah.
Too?
Exactly. So just trying to be helpful. One of the other strategies that our palliative care team has kind of introduced to us is utilizing the atropine drops in the buccal region, so in their cheeks. So putting those drops in to kind of dry things up, particularly if you are worried that they have problems mucus plugging down below. So giving a systemic medication to kind of dry up their secretions, such as glycopyrrolate, really could potentially exacerbate a mucus plugging event in their lungs. And so if you're worried about that, but they have lots of oral secretions, one of the strategies that we've used frequently is just putting atropine drops in the cheeks and trying to get the saliva to dry up that way. I would say I don't see a whole lot of effectiveness with it, but it's something to kind of add into the mix if you're kind of struggling from that standpoint.
This is something that definitely comes up quite a bit in our unit. Think about those chronic kids who have chronic respiratory failure. I have seen how we're a bit more wary to use glycopyrrolate if we're worried about thick secretions that might plug off the tube. So we definitely reach for the atropine drops.
Yeah, they definitely have a role and they're definitely beneficial. But I think if you talk to the bedside nurses, they're like, yeah, I still have a lot of secretions. But I think they definitely have a role and are helpful.
Well, before we move on from upper airway obstruction, anything else you want to cover before you keep on moving down head to toe?
I don't think so. I think we kind of touched on the big points.
Okay, so probably the most common reason kids get intubated is for respiratory failure due to pulmonary problems. So let's talk about the lungs.
Yeah.
What comes to mind here?
So when I talk about lungs, so you talk about the chest cavity, right? So as you're moving head to toe, you get from the neck area down to the chest cavity. And in the chest cavity, you have both the heart and the lungs. And so the first thing that you need to consider is, and I forgot to mention this at the top, but is really the reason why they got intubated resolved. So as Zach mentioned, a lot of kids are getting intubated, right, because of problems with their lungs, respiratory failure because of RSV or because of COVID. And so now we need to assess, are their lungs better? Are they good enough to get extubated? How do you determine that? And what's the best assessment for that? So we really want to have a good understanding of what their compliance is. And so Gina, tell me a little bit about how you assess for improvement in lung compliance and what numbers might you look at to help you decide, their compliance is getting better.
Yeah, so I think two different things. I would look at their blood gas to assess for their gas exchange and seeing how, well they're blowing off CO2 and how well their lungs are oxygenating. So looking at that, if you have an arterial blood gas, even better. That's number one thing. And then the second thing is if you have good gas exchange, then you're able to wean your ventilator in the support that you're providing. And so multiple things that I'm looking at on the vent is one is compliance. So if we started off with poor compliance for whatever pathology was happening in our lungs, has that improved? Or is this a patient that has poor compliance at baseline and do they just have fibrotic lungs? And this is something that is not going to improve. So just kind of making that assessment. But really, I'm looking at compliance and seeing what kind of tidal volumes they're generating. And then from an oxygenation standpoint,
So Gina, I'm going to pause you and go back to that compliance topic. So you said compliance, but how do our listeners assess that? You said tidal volumes, but I mean, what does that mean? What tidal volumes in what setting? I'm confused.
Yes, thanks for pointing that out, Alyssa. So I'm looking at peak pressures generally when I'm talking about compliance and the tidal volumes that the patient is able to generate depending on what type of ventilator mode they're in. So if we're looking at an SIMV PRV type mode, then I'm looking at the peak pressures that are being generated for a set tidal volume that's being delivered on the vent. And then if they're in a pressure control mode, we're obviously setting a PIP, and so seeing what kind of tidal volumes they're generating with a set pressure control.
And what number do you use to kind of decide this compliance seems reasonable and I'm okay extubating here? So if you're on PRVC, what PIP are you looking at and saying oh yeah, I think I'm okay?
I would say about a PIP of less than 20 would be ideal, but less than 25 is I'm generally okay with. But PIP of 20, you have an A++.
Yeah.
From me.
Yeah, and kids who have healthy lungs, so you take an example of a kid who got intubated for a seizure or for an ingestion, you'll see that their peak inspiratory pressures are I don't know, 8, 10. And so having a good understanding of where you're at physiologically, right? So having a PIP of less than 20 is ideal, great, but you may have kids that you're I'm okay extubating at 22, but really, staying less than 25, I think is really important because they have to have enough strength to continue to generate their tidal volumes when you extubate them without that added pressure. And then thinking about compliance in the setting of oxygenation, the other number that I look at is going to be PEEP. So when you think about PEEP and oxygenation, they are hand in hand because PEEP is going to affect your mean airway pressure. But what kind of PEEP level are you hoping to be at when you extubate?
Yeah, so I'm generally okay with a PEEP of 6 or less. I know our standard practice is not to wean the PEEP less than 5. I know some institutions do that, but in our institution, we usually don't wean it less than 5, but I'm okay with extubating with a PEEP of 6 or less. And, that can be changed depending on what's going on with the patient. Once again, you can definitely extubate with a higher PEEP. Once again, if you had an obese patient that may need a very high PEEP to move the chest or keep the chest inflated, then you might have to move your standard in terms of when you would extubate that patient, and you may extubate them on a much higher PEEP than just a PEEP of 5 or 6.
Hey, I'm Ciara Minova, a graduate student of Psychology and Neuroscience of Mental Health at King's College London, and I'm so excited to share with you my new podcast, which is called Behind the Stigma. Every other week, I will be mainly talking to the podcast clinical psychologists, clinicians, researchers, educators in the field, you name it, basically people that I find so inspiring and that will help us understand the latest research, concepts, but also complexities and controversies surrounding mental health. These are going to be some great discussions and a peek into the fascinating world of psychology, neuroscience, and psychiatry.
I think you bring up a good point. So I'm just kind of reminding everybody physiologic PEEP actually is closer to 4. When we have pediatric patients, their FRC is very close to their closing capacity because they don't have a rigid chest wall because of their cartilaginous chest pieces, right? Their ribs are still cartilaginous. They don't tend to recoil as well. And so they have a tendency to develop more atelectasis. So the thought process about keeping the PEEP a little bit higher at 5 is to try to prevent that atelectasis from developing. And just like Gina said, there are reasons to keep the PEEP a little bit higher when you're extubating. So for instance, we have a couple chronic kids who, if you drop their PEEP while they're on the ventilator to less than 8, they tend to kind of reaccumulate atelectasis in areas of scarring of their lung. And so oftentimes it's better to keep their lungs open and get them extubated than weaning their PEEP down to 5. And so a strategy that I might use is weaning their PEEP to as low as we know that they'll tolerate, so around 8, and then extubating them straight to their BiPAP support. So these are kids who have like nocturnal BiPAP and just take a little bit of time, and it takes a little bit of finesse to help them through that extubation process. So it's not like a hard and fast rule, and again, more of that art of medicine when you're thinking about those numbers.
For sure. So to simplify things, we want the patient to demonstrate evidence that their lung disease is improved. So we think about ventilation and oxygenation. If there's ventilation, we want to make sure they're getting a decent tidal volume, maybe 6 to 7 mLs per kilo vital body weight on peak pressures less than 20. And then oxygenation, we want them to be oxygenating appropriately on a reasonable FiO2, maybe 30, 40%, in a PEEP 6 or less. And of course, in the context of what is normal for that patient. If they need a higher PEEP at baseline, maybe they extubate on a PEEP of 7 or 8.
Exactly. And I think you bring up a good point about FiO2. So like, what FiO2 requirement are you willing to extubate on? So I'd have usually a nice long discussion about like, what FiO2 do you get worried about? But generally speaking, when we're talking about extubation, I hope that they're usually on an FiO2 of less than 40. So then if they do struggle getting extubated, then we have room to escalate their oxygenation support getting extubated. That is kind of my general rule of thumb. There are some other caveats to that we don't necessarily need to talk about. Especially since I think what the next kind of more important thing is to understand the kind of spontaneous breathing trial. So how do you get data that supports that all of these things are in an appropriate spot? And so that's where we get into that spontaneous breathing trial. And so there are multiple ways to do this, along with everything else in medicine. The strategy that we utilize at our institution is we typically utilize a pressure support on top of a CPAP. And so oftentimes people will call it a pressure support CPAP trial, but really that's a misnomer. It's really just a pressure support trial. So in this particular setting, you are going to set your PEEP at your lower end. So if you are going to wean off or extubate on a PEEP of 5, you want the PEEP to be 5, and then you add that pressure support on top of it. At our institution, we utilize a standard level of pressure support based on the size of the endotracheal tube. And the kind of idea behind this is that this added support is overcoming the resistance of the breathing tube. However, I'll give you this caveat. There are lots of studies that support the idea that actually pressure support is over supporting the patient, and that you don't actually need the pressure support in order to overcome the resistance of the tube. But we will go along with what our institution does for kind of the sake of the discussion. So for instance, if a patient had a breathing tube that's a 3.0, our institution would set their pressure support of 12. And so what we're going to do is we're going to go ahead and evaluate the patient on a pressure support trial where they have their support set at 12, PEEP of 5. We're going to look at their FiO2 requirements, their level of tachypnea, the tidal volumes that they're able to generate. And then I also look at some other factors, particularly if they had lung disease. I want to see if they develop atelectasis while they're on the support trial, and I want to make sure that they have adequate oxygenation and ventilation. So I might grab a blood gas. So in somebody that I'm really worried that has a history of lung disease and that's why they got intubated, I may have them do a support trial and say, hey, why don't you go ahead and grab a chest x-ray and a gas after they've been in that for about an hour or so, to just assure that their lungs have stayed adequately open and that they haven't developed hypercapnia in that particular setting. That's probably a bit aggressive and probably not necessary. And I would say I don't know that anybody else in the unit particularly practices that way. But some of these little babies who have like a lot of lung disease and develop a lot of atelectasis, I think it's helped me be a little bit more cognizant about getting them ready to extubate.
Sure. And something that we'll watch closely during a spontaneous breathing trial is end-tidal capnography, so end-tidal CO2. And I feel like that can really give us a lot of good data about, if we see that number climbing, maybe we're not ventilating appropriately.
Yeah, and I think that is perfect. It's a great non-invasive way to evaluate their ability to ventilate. And if we have the ability to do that, that is a great way to monitor it. Oftentimes in little babies, our end-tidal CO2 detector has a lot of dead space. So sometimes that'll get taken off and they'll use a TCM or a transcutaneous monitor instead, but following that as well.
This is interesting because Alyssa, I'm hearing you get hard numbers. I want to see the x-ray. I want to see the gas. Zach, I'm seeing you watch the end-tidal. And in my experience, you're running around the unit in the morning and you're like, how'd the ERT go? And the RT goes, no, to Kipnick with the ERT. And then we hold off on extubation for a day. And so it's just such a spectrum of information.
Yeah, it is. It is. And I think, we definitely have the respiratory therapist kind of chime in and tell us like, oh, how did it go? And sometimes, they don't pay close attention. And so it's a little bit challenging to kind of get that detailed information. When I have ER residents with me, they often will ask me about more quantifiable ways to assess the spontaneous breathing trial because there's a lot of adult literature that supports the use of the rapid shallow breathing index or the compliance resistant oxygenation pressure index. And those are things that we don't typically utilize at the bedside, but there's a lot of data behind them and I think can be helpful in those situations. And we have kind of the details for that in our blog post. But certainly, I think there's more objective ways to kind of get that data too.
Oh, yeah. I guess my other question is about the way you think about frequency and duration of these spontaneous breathing trials, extubation readiness trials. Is your mental model, this is one time only 30, 45 minutes, and then if it goes well, we extubate? Or is your mental model, in some older kids, we go for longer, and that's great. And I've also seen 2-hour ERT per day, and then the lungs slowly de-recruit and now you're out of a space for extubation,
Yeah. So I think it's a little bit variable. So one of the other things about me that you guys may not know is that I'm a huge advocate for early mobilization and kind of keeping your patients kind of engaged in the activities of regular daily routines. And we know there's a ton of literature about diaphragm atrophy and how quickly that happens when kids are intubated. And so my goal is to do the least amount of harm as possible. And I use these breathing trials in that effect. And so particularly in patients who are very weak and have been intubated and sedated for a very long period of time, I might use these breathing trials as more of sprints. So more like exercise for their diaphragm. For instance, we had a patient who was intubated and sedated and paralyzed on an oscillator for a month. She was able to recover. And as we were working towards getting her extubated, we really needed to exercise her diaphragm and get it back to a spot where it was functional on a, regular basis. And so we really used the spontaneous breathing trials more as exercise. And so she would do those 2-hour daily sprints where we would say, okay, we want her to really do her own work for 2 hours. But then we want to be able to give her rest so she doesn't de-recruit her lungs and doesn't go back into the spot where we can't get her extubated. And so in those instances, I will use the spontaneous breathing trials in that fashion. Kids who have been intubated for a shorter period of time, it's more like a couple of days, 2 to 3 days, I might say like, hey, let's just do the spontaneous breathing trial in the morning, get the tube out and move on. And so I think it's really patient dependent. But if they have great compliance, there's nothing wrong with their lungs. We had a kid who we threw an auto mode, which essentially is a spontaneous breathing trial with a backup rate because he was more comfortable in that setting. And he was a kid who was intubated for seizure. Now we're allowing his diaphragm to function the way that it's supposed to. And hopefully we're preventing atrophy. And so that's kind of the thought process that I use.
Say you have that patient with ARDS that's resolving, maybe they're a little bit older and have a bit larger endotracheal tube. Is there any part of your practice where you might use a straight CPAP trial or a T-piece trial to get a better idea of their pulmonary compliance prior to extubation?
Mm-hmm. Yeah, so I will ask the RTs to actually put our kiddos in straight CPAP and just kind of get a good sense. I can't remember the last kid. Oh, yeah, it was one of our more chronic kids who had bad ARDS and was recovering. And I was like, I just want to see what this looks like, because this is not part of our institution's normal practice to put them in a straight CPAP trial. Some of our attendings really prefer them. So they will ask the RTs to do that. And so I asked the RT, I was like, just put them in a CPAP of 5 and see what happens. And sure enough, The kid generated like huge tidal volumes. He got a little bit tachypnic, but didn't look terrible. And it was a great way. Our institution does not use T-pieces. And so I cannot provide you any detailed discussion about even what it is. I mean, I know generally what it is, but like we don't generally utilize it. And so I would not be that great of a resource for you.
Zach, is this something that you guys do? If a patient was not connected to the vent, I would freak out walking by the room, right? Like,
so I feel like it's more of a discussion than it does get implemented. Usually it's a great conversation on rounds. We talk about how this patient would be great for a T-piece trial. And then when it gets to the bedside RT, they're like, no, I'm not disconnecting from the vent unless you're going to stand here the whole time. Yeah. And then you say, well, there's 40 other patients. I can't really stand here for this entire ERT. But I guess long story short, if a patient can breathe on a T-piece trial when they're not getting any positive pressure, they should be able to oxygenate and ventilate with that tubes out. But you lose the ability to monitor their tidal volumes. You don't have an end-tidal CO2 anymore. So you're left with transcutaneous CO2 or getting a blood gas. So it definitely is higher risk.
Yeah. And we were actually just having this conversation when I put this kid on a CPAP trial about other institutions. We have a hospitalist, and she was like, oh yeah, we did that all the time where I was. And I was like, yep, we just don't do it here.
Thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. Check out pedscrit.com for detailed show notes, and visit @CritPeds on Twitter and @PedsCrit on Instagram for real-time show updates. Thanks again for listening.